Our final session today is also from the Quality Systematic Review Committees, and they will be providing an update on venous thromboembolism in pediatric surgery. I would like to welcome to the stage Dr. Baird from Children's Hospital Vancouver, Dr. St. Peter from Kansas City, Dr. Kelley-Quon from Children's Hospital LA, Dr. Yousef from Montreal, and Dr. Gross from Goriab Children's Hospital Morristown Medical Center in New Jersey. Thank you all.
Yeah, good morning, and thanks for still being here, those in person and online. So we'll talk about venous thromboembolic disease in children. With improved survivorship and increased use of indwelling devices, coupled with the idea that VTE is a quality metric in things like Pediatric NSQIP and Pediatric Trauma Society, there's definitely a growing awareness of its importance in children, but there remains a lot of heterogeneity across practices and between populations. So we'll try the audience response question here. This is a scenario that is not unfamiliar to all of you. A previously healthy 14-year-old female is involved in an MVC and sustains a femur fracture requiring ORIF. She also has a grade 3 spleen and multiple rib fractures. During her admission at my institution, this patient would be treated with, and you see the choices there, low molecular weight heparin, aspirin, mechanical prophylaxis, a combination, or none of the above. And I don't know if we have the same tech as Elizabeth, who figured it out last time, but Shawn, can you see? But I'm going to presume there's some heterogeneity in the audience, so thanks for that. And with advancing, we're just going to get to the next scenario, and that's okay because this is just to tease you all. They're the same responses, but a different scenario. A 4-year-old undergoes elective radical nephrectomy for a presumed Wilms. During the perioperative period at my institution, this patient would be treated with same response options. So that second one, there's far less heterogeneity, I think, is the takeaway. Thank you, I see that. Can we go back to the slides? Thanks. So this is Team VTE. I would just like to take a quick second and recognize not only Team VTE, but Team Pneumothorax and all members of the Outcomes Committee for laboring kind of in the dark all year to create these high-impact evidence-based reviews for us and the membership. So thank you, guys. For this review, we broke our questions about VTE into 4 parts: epidemiology of VTE, the utility of screening, the benefit and the magnitude of effect of mechanical prophylaxis, and pharmacologic prophylaxis. We constrained ourselves by looking at only children, and we stuck to 2000 and onwards. We did exclude 2 important populations, that is, those studies that looked just at central venous access, and we eliminated the hematologic literature looking at those patients with hypercoagulable states. As you'd expect, we adhered to best practice PRISMA guidelines. We identified over 6,000 papers and ultimately whittled them down to just over 100, and you see them sort of in their 4 bins. We used the Oxford, which is really the industry standard, to assess risk of bias and levels of evidence. And so what is the epidemiology? To try to address this, we aggregated 69 studies. As you'd expect, the majority of them arose from the United States. There was an increasing trend in publications over time. Most of the population were represented by administrative databases. These are things like FIS, NSQIP, and the National Trauma Data Bank. There were a series of good retrospective case reviews, however, that did provide lots of granularity. So when it comes to elective surgical procedures, we aggregated nearly 3 million patients and had an overall incidence of VTE of about 3 in 1,000. A couple of populations worth noting are IBD patients that underwent abdominal procedures had a rate that was nearly 5 times the average. And a bit counterintuitive, but the elective spine procedures actually had a rate that was 3 times lower than the average. And we ascribed that to good protocolized care and prophylaxis. There were some trends that we noted. There was a bimodal distribution with peaks both in the neonatal period and older teens. Additional correlations included a transfusion during the procedure, prolonged anesthesia, an operation for malignancy, a procedure for congenital heart disease, female gender. Interestingly, BMI did not correlate. Looking at our trauma population, we aggregated over 4.5 million patients and had an overall incidence of 0.25, that is 2.5 patients per 1,000. A couple of populations again stand out. The TBI, severe TBI group, that incidence doubled, and there was one order of magnitude higher, that is a 10-fold increase in those patients that had a severe spinal cord injury. The incidence correlated linearly with age, and there was additional correlations with the need for major surgery, the presence of a central venous access, in this instance BMI, and length of stay. And with that, I invite Shawn back to the podium to discuss the utility of screening.
All right, when we talk about screening, we're talking about getting an ultrasound to look for the DVT in the asymptomatic patient. And of the 15 manuscripts that made it out into this bucket, we had 4 that we were able to use for analysis. And most of the work being done in the United States is coming out of Milwaukee. The initial publication forwarded this guideline, and we're going to focus on the patient who's high risk, so meaning they're a high risk of bleeding and a high risk of a DVT. And that's somebody who's over 13 with a trauma, or somebody who's under 13 and has 4 of what you see listed under a risk for VTE. If they're high risk for both and they're still in the ICU on day 7, they recommend a screening ultrasound to look for a DVT. From that, this was initially published in 2012, they rolled that into a prospective observational study for the next 5 years. And nearly 600 patients were admitted to the ICU with trauma, and 56 met screening criteria, of which 49 got an ultrasound, and a third of them had a DVT. And then of the 37 high risk, 30% had a DVT, of which 6 of those 11 were asymptomatic. Using these data, they rolled it into a proposal to the Midwest Consortium, of which 8 of the centers were able to participate. This work's being led by David Gourlay and Peter Ehrlich. And the study population is those who are admitted to a trauma unit under age 17. And so far, they've had 350 patients, and they're going to be examining the risk of VTE, the rates of prophylaxis, the exceptions to prophylaxis, the safety of prophylaxis, and the use of screening ultrasound, which is primarily being performed at only 2 sites. So we look forward to seeing what comes forward, but at this point, with the limited data that's out there on screening, we cannot recommend screening the asymptomatic patient for a DVT, in which case you would inherit the risk of bleeding from treatment. That's the trauma population. Moving over to the elective surgery population, there's only been 2 studies that have looked at this specifically. 91 neurosurge patients who had pre- and post-operative ultrasounds, and there were no DVTs detected. And then 40 patients undergoing spine surgery who underwent serial ultrasounds. Interestingly, they found 2 patients with a small DVT in the early image, and then it went away with the subsequent images. Both studies ended up recommending not doing screening ultrasounds for these patients. Obviously, these numbers are far too small for the incidence of disease that we're talking about. But again, we're left with an inability to recommend a screening ultrasound in patients who undergo elective surgery. And these are both grade D recommendations. On to question 3, Lorraine.
All right, so the third question that we wanted to address with our systematic review is about the utility of mechanical prophylaxis. Our question was, what is the benefit and magnitude of effect of mechanical prophylaxis in children? And when we use this term, we're talking about SCDs, stockings, and initially when we started this review, we also wanted to include early ambulation, but we found that this really wasn't consistently studied in the papers that we pulled or evaluated paired with the outcome of VTE. So we identified 24 manuscripts. The manuscripts that we identified and include are largely guideline implementation studies or studies that report on the concomitant use of mechanical prophylaxis with pharmacologic prophylaxis, and also several studies looking at placement of IVC filters. Several papers that we evaluated alluded to mechanical prophylaxis but were excluded due to the inability to select out the effects of mechanical prophylaxis alone. So the first aspect of our review looked at reported usage, and the take-home is that it's very low. We included 9 papers for this particular subset of this question. There was a retrospective review of patients undergoing colectomy for IBD, and SCDs were only reportedly used in 32% of pediatric patients. In a retrospective review of children undergoing orthopedic surgery who developed a VTE, 93% had not even received mechanical or pharmacologic prophylaxis. So in another retrospective study, 10% of children undergoing orthopedic surgery with complex neuromuscular conditions received mechanical prophylaxis. And a study utilizing a pediatric trauma database showed that 13.8% of trauma patients in the PICU received mechanical prophylaxis, and a subsequent 3.4% also received pharmacologic. So the next question, we're not using it very much. Well, when should we use it? So current guidelines recommend the use of mechanical prophylaxis in patients who are high risk for VTE, with the addition of pharmacologic prophylaxis if there's no current contraindications. There's a single institution retrospective study of over 1,400 spine surgery patients, and as you'll see is a recurring theme, VTE incredibly low in general in pediatric surgical patients and in this population. The conclusion of this particular study suggested that mechanical prophylaxis is adequate in low-risk patients. Something also important to address is the utilization of IVC filters. They can be considered in children with contraindications to pharmacologic prophylaxis. In a retrospective study using the NTDB, they identified placement of an IVC filter in 0.18% of over 116,000 patients. So this is very rare intervention performed in the populations we care for. These were associated with injured children who had high injury severity scores, longer hospital stays, and ICU stays. Important to note, in one retrospective single institution study at a level 1 trauma center, they evaluated 59 patients within that center who received a filter. 47 patients received them prophylactically, but filters were only reportedly retrieved successfully in 12 patients, and 10 patients had an associated filter-related complication. So if you're going to decide to place a filter, families need to be adequately counseled on the risks associated with filter use, and also a plan for filter retrieval also potentially needs to be put in place. Standardized guidelines improve the consistency of providing mechanical prophylaxis. There are several guidelines posted that we included for our review. A lot of them highlight that utilization of electronic health records may improve implementation of mechanical prophylaxis. In one single institution retrospective study, the incidence of VTE decreased from 5% to 2% for their high-risk trauma patients, and implementation improved from 48% to 81%. But really, there's a lot of guidelines, but there's no head-to-head comparisons of which guideline is most efficacious to decrease morbidity. We do want to highlight that the Pediatric Trauma Society and East Trauma Guidelines have published the following. They conditionally recommend that mechanical prophylaxis be considered alone or in addition to pharmacologic prophylaxis for 1, hospitalized children greater than 15 years, and hospitalized children less than 15 years who are postpubertal with an injury severity score of greater than 25. So these are injured children on our trauma services. So our recommendation for utilization of mechanical prophylaxis for surgical patients is that SCDs should be considered in children at risk for VTE when they are non-mobile. IVC filters may be considered in select patients, but you have to counsel patients appropriately about the risks, and you have to have a plan for retrieval. And implementation of guidelines and utilization of an electronic health record may improve utilization of mechanical prophylaxis, which we very infrequently use in pediatric surgery. Regarding mechanical prophylaxis for injured children, we do endorse the EAST and PTS guidelines to consider mechanical prophylaxis alone or with pharmacologic prophylaxis in the populations listed here, but please note this is a grade D recommendation and level 5 evidence. All right.
So we're going to look at pharmacological prophylaxis and what the benefit is and magnitude of effect for pharmacological VTE prophylaxis in children. And then we also added a question of what is the ideal medication and dose. With regards to the first question, we looked at 8 studies which discussed the benefit of pharmacological VTE prophylaxis, mostly retrospective reviews, and the majority of the populations studied were trauma patients. So multiple studies showed a low incidence of VTE when receiving pharmacological prophylaxis, but as Dr. Baird alluded, it is a very rare complication. The majority of studies did not show a statistically significant reduction in risk of VTE with pharmacological prophylaxis. There was one large study of over 180,000 patients, which showed a higher risk of VTE in those receiving pharmacological prophylaxis, but it was severely confounded by indications. Institutional guidelines for pharmacological prophylaxis does significantly reduce the risk of VTE. And so our recommendation is that pharmacological prophylaxis should be considered in patients at high risk for VTE and low risk of bleeding in the context of a clinical guideline, but this is a grade C recommendation with level 3 evidence. For the second part of our question, we looked at 5 studies which discussed the type of pharmacological prophylaxis, again, mostly retrospective reviews and mostly in trauma patients. Low molecular weight heparin was superior to unfractionated heparin with more than a 50% risk reduction when using low molecular weight heparin versus unfractionated heparin. Measurement of an anti-10A did not affect risk of VTE. And the dosage was in general 0.5 milligrams per kilogram per dose, subcutaneously Q12 hours. And in neonatal populations, you could consider a higher dose if they're less than 2 months. So when pharmacological prophylaxis is initiated, low molecular weight heparin is superior to unfractionated heparin. The usual dose is 0.5 milligrams per kilogram per dose, sub-Q, Q12, and there's no evidence to support monitoring anti-10A levels. Grade B recommendation, level 3 evidence. Dr. Gross is going to speak to us about the APSA Quality Toolkits currently available.
Good morning. I think it's still morning. I'm part of the Quality and Safety Committee, and today I want to take you on a tour of the VTE Prophylaxis Toolkit, show you how to access what's currently posted, and then I'll take a couple minutes to describe specifics of one of the QI projects that is located in the toolkit. I have no disclosures. But first, I wanted to take a quick poll. We're curious which institutions or how many institutions actually have a VTE prophylaxis guideline. Okay, so actually relatively evenly distributed there between having one that uses both mechanical and pharmacologic and not having a guideline. So for those of you who don't have a guideline or are currently working on a guideline, please visit our Quality and Safety Toolkit in our VTE prophylaxis folder. So if you open up the folder, you'll see that there are 5 institutions that have posted their QI projects, and there is also a folder labeled Recent Research. Within the Recent Research folder, there is a document with a list of journal articles and links to those articles on PubMed. These articles have been identified using the search criteria at the top of the document. This table summarizes the current projects that are in the toolkit. The 5 institutions, 4 of which are ACS Level 1 trauma centers. All 5 institutions are using both mechanical and pharmacologic prophylaxis in their guidelines. Only 2 are currently using ultrasound screening for patients who have contraindications to pharmacologic prophylaxis, and thankfully all 5 of these institutions have shared their current guidelines or algorithms for other institutions to reference. So next I want to talk specifically about a QI project that was performed at the Children's Hospital of Richmond at Virginia Commonwealth University. So at Richmond, they received a high pediatric TQIP benchmark for their VTE. So they identified this as a problem, and this project was designed with the goal to identify pediatric patients at high risk for VTE, to reduce morbidity and mortality of VTE, and to improve their national TQIP benchmark. So what they did was they identified their stakeholders. They invited patients, surgeons, both pediatric and orthopedic, nurses, residents, pediatric critical care intensivists, pediatric hematology oncologists, and pediatricians to come together. They had monthly meetings for about a year where they reviewed the literature, much like we have done today. They defined their own inclusion and exclusion criteria. Based on the literature, they developed their own scoring sheet for screening for patients for VTE, and they also designed education tools to train all the providers that will be taking care of these patients for the study. So some of the questions or obstacles that they identified during the design of their QI project, very similar to the questions that we just reviewed. What is the targeted age for screening for pediatric VTE? What is the targeted patient population? Is it every pediatric patient that is admitted to the hospital? Is it just the patients that are going to be immobile during their stay? Is it the trauma patients? What team member should be doing the screening, and how should the screening be done? On paper, utilizing the electronic medical record. So what this team came up with was a screening tool that they entitled Venous Thromboembolism Risk Assessment Score, or VTRAS. And this is a screening tool that they developed to assess the VTE risk in pediatric patients. They utilized this screening tool on admission for all pediatric patients, and then sort of arbitrarily chose every Thursday as a weekly reminder for the patients to be screened weekly. This is a copy of the VTRAS scoring tool. The column on the left are the comorbidities that equated the highest risk for VTE. The column in the middle are the comorbidities with a little less risk, and then the column on the right are the comorbidities with the least risk. So these comorbidities were tabulated, and the final score is the VTRAS score. The second page of this screening model then goes on to describe what to do with the score that you've tabulated. So if the score was less than 3, patients were considered to be low risk. Ambulation was encouraged. If the score was between 3 and 5, the risk was considered to be moderate, and the use of SCDs were encouraged. If the score was greater than 5, the risk was considered to be high, and chemical prophylaxis was encouraged, as well as consultation of the hematology oncology service. There's also a list of exclusion criteria, very similar to most institutions. And then finally, this institution also utilizes ultrasound screening for patients who are high risk for DVT, but have one of those contraindications for chemical prophylaxis. There were also some teaching materials that were generated by the stakeholder group. They designed some PowerPoint slides to educate nurses and other providers that will be doing the screening, as well as providing the therapies. There were also instructions designed for providers to use the electronic medical record to utilize the screening. And these are thankfully also included on the Toolkit website. So at Richmond, VTRAS screening was introduced in 2017, and they have reported no subsequent symptomatic VTE since introduction of this QI project. So they have met their subsequent TQIP benchmarks. And then they noted some modifications that they made along the way and also some challenges that they encountered. This project was initially piloted with just pediatric patients 12 to 14. They were then able to expand to ages 1 to 14. And part of that was that they had trouble with finding appropriate sized SCDs for the younger patients. So that did delay their implementation. They also commented that they did start out with paper forms, and this was very difficult in identifying who filled them out, where did they live, were they filled out correctly. So when they did transition to electronic medical record format, it made that much easier. Calculating the score was easier. It directly linked to orders, so that really eased their transition. And then, like any QI project, data collection has been a challenge. You always want to be able to sort of prove your feasibility, your safety, and your efficacy. So are you making sure you're capturing all the patients that qualify for your QI project? What is your compliance? And are there any potential complications from your therapies? So I just want to thank Dr. Patricia Lang and Dr. Victoria Kuster, who gave me insight into their QI project to share with you today, and then Dr. Kyle Van Arendonk, who was my partner on the QSC committee for this presentation. Thank you.
I suppose we have a audience and or the online chat, recognizing that people may have planes to catch.
Great work. So these are really helpful recommendations, both of the toolkits. I'm just going to talk about the first one too, since you didn't have a chance for questions on that. But question, Shawn, or if you know from your other panel, so you say we don't know what pleural procedure to do, but I guess I'm asking you, what would you do? So that's question number one. Question number two for both panels, patient stakeholders, and there was like a little smattering of it, but in both of these very interesting interventions, VTE prophylaxis and pneumothorax involving chest tubes, what are the patients and the families? We saw some patient satisfaction data, but what do the patients and the families want us to do? Like with pneumothorax, I guess they want to get out of the hospital. And if you give them the choices, they're like, go ahead and do that blebectomy because I'll be out sooner. And should that factor in? So patient stuff, and also then what would you do?
Well, I think you opened a door for an entirely separate avenue of investigation, which is what are the patient and parent preferences when it comes to treatment. Having the experience with just finishing the trial of non-operative management of appendicitis, I would imagine that you would see a split where the parents are more concerned about recurrence and the kids are more concerned about not being poked. And that's what I would expect would probably bear out. So an opportunity for observation, I think any kid would go for. And put into context altogether, I think you would have to have a lot of data to see where families come in. And I think you would, like with appendicitis, you would see differences in regions and across countries. What would I do? I would encourage, and I will enroll in any randomized trial that gets started. Brian, get to work, because that'll be exciting. We currently just do a mechanical paradesis / pleurectomy. We had this conversation yesterday, is how do you define pleurectomy, since by the time you finish your mechanical paradesis, half the time you've done a pleurectomy, you've ripped half of the apical pleura off. But that's what we currently do, is a stapled staple off the apex and do a mechanical pleurodesis. We did a chemical pleurodesis for a little while, but we kind of backed away from that. It does seem to cause a little more pain.
Adam Gore from Sioux Falls. Actually, my question is, it's a great segue to my question, because when we reported these studies, there wasn't much on symptoms, postoperative symptoms, with the various, methods of pleurodesis. And when I do these, I always do a mechanical pleurodesis. I don't add the chemical pleurodesis initially. First of all, I like to have something in my back pocket if they recur, because if I've done both the first time, then the next time, I don't know if that logically makes sense, but that's sort of how I approach it. And I worry that if you add chemical pleurodesis in addition to mechanical pleurodesis, you actually might increase pain without any real benefit to that patient, because they are unlikely to recur in the first place.
All I can say is that there is, again, a paucity of data on that particular aspect of treatment to be able to really address the question. So that, I think, is going to be the next step, that as we move toward more comparative evidence, then asking the next question, then what? If we can get to the lowest possible recurrence rate, then I think we can ask the question, then what? Then how do we make it as palatable as possible for the patients? How do we make it a better experience once we find the best operation? And I'm skeptical that we're going to have a clear winner based on all the data that Don showed. With how many different studies looked at it in different ways, and there wasn't one trend that emerged as a clear winner, I think it's going to be difficult for us to identify a clearly superior operation.
Yeah, we have a virtual question from the chat. If there is an episode of pain and a small apical pneumothorax after VATS, and the lung remains stuck to the pleura everywhere else, is that considered a failure? The lung did not collapse as is intended in the surgery.
So I'm interpreting that as you still have what looks like a pneumothorax after your VATS, and that seems to be universally ignored and considered within the success range. Although it's not clearly defined in most studies, expecting some apical pneumothorax after surgery is expected.